Hello. Let's talk about this SDL titled Malabsorption and Diverticular Disease. I'd like to start this one by bringing up the fat-soluble vitamins and what deficiencies of the four fat-soluble vitamins present as, because they might show up on an in-house exam. They're probably definitely going to show up on boards. They love to test vitamins. There's a lot of different vitamins. There's a lot of different clinical presentations of different deficiencies. So vitamin A deficiency is going to affect your eyes predominantly because you need vitamin A to replenish 11-cis retinal, that's retinaldehyde, which is going to complex with the visual pigment enzyme rhodopsin, and it'll interact with the photon and undergo a conformational change to transretinal. And the rhodopsin protein gets modified too, and that leads to a cyclic GMP-mediated signaling cascade, and that's how you see. So night blindness is the most common presentation, as you should know, of a low vitamin A status. And you're also going to see dry, scaly skin. This is out of first aid, describing xerosis cutis. Flaky skin is another good way to think about it. And essentially what's happening there with the skin is that keratinocytes are very heavily dependent on retinoic acid. They have a high concentration of surface retinoic acid receptor for their differentiation. So to turn into an appropriate skin cell, they need a lot of vitamin A. So you're going to see some skin problems with the vitamin A deficiency there as well. And then a last clinical sign you might see in a hypovitaminosis A are these spots called Bitot spots on the conjunctiva of the eye, and they've got this foamy appearance to them. Hypovitaminosis D, you should know vitamin D is involved in bone health, and so the predominant presentation of a low vitamin D level is going to be rickets in kids, and we call that osteomalacia in adults, because you need vitamin D to not only absorb calcium and phosphate from the intestine, but to push it into bones. And so if you don't have vitamin D, your calcium is eventually going to drop. And so if your calcium drops, you can go into what's called hypocalcemic tetany, where your muscles start clenching up. And how you would diagnose that clinically is through assessing for Chvostek's sign, and you're going to tap on the facial nerve of a patient, and if their jaw locks up, then you're going to infer hypocalcemia from that positive sign. And vitamin D is ingested usually as active D3 cholecalciferol from animal sources. D2 ergocalciferol is a little bit different. We can get that from plants, but we can also make D3 from sun exposure as well. But the dietary component of our total vitamin D content is pretty big. Hypovitaminosis E, this is one that people don't tend to know a lot about. Vitamin E is a membrane-based antioxidant. So you have vitamin C and vitamin E. Those are your two main antioxidants. Vitamin C is a cytosolic antioxidant. It's pretty soluble. Vitamin E, on the other hand, is lipid soluble, and so it sticks in membranes and performs oxidation of any lipid radicals that might form, which are pretty frequent. So if you don't have vitamin E, you have poor cell membranes. And where this manifests first and foremost is in red blood cells, because they're nothing but a bunch of membranes, and you got a ton of them all over your body. And if you don't have enough vitamin E to maintain the integrity of these membranes, you're going to see what's called acanthocytosis. And some acanthocytes are at the bottom of the current screen. And as you can tell, they're really spiky red blood cells. And the reason they are is because they're losing membrane integrity due to oxidative stress. And so this can lead to a hemolytic anemia. And another common presentation of a hypovitaminosis E is going to be a lateral column degeneration similar to a B12 deficiency. And you're not going to see, however, the megaloblastic anemia that you would in a B12 deficiency if you're purely vitamin E deficient. And where this is going to come up again in this SDL is with Abetalipoproteinemia. And finally, vitamin K. This is your last fat-soluble vitamin. K for coagulation. You should know that vitamin K is activated by this VCOR enzyme, which is called vitamin K oxidoreductase. And it's going to, once activated, allow for the maturation of four specific clotting factors, 2, 7, 9, and 10. Sound familiar? If they are, that's because those are the clotting factors that warfarin is going to deplete. And so a vitamin K deficiency thins your blood, similar to if you were on warfarin. Obviously, some patients don't need to be on warfarin. They have thin blood already. And so how does this present? Well, microhemorrhages, petechial hemorrhages, easy bruising possibly, although you won't catch a lot of these. So that's our fat-soluble vitamins. Let's get into the text. We begin with a review of the anatomy of the small intestine. You've got a duodenum, and at the ligament of Treitz, which is a suspensory ligament spanning from about T11 or so from your diaphragm down to your small intestine. This ligament of Treitz is going to root the gut in place and kind of hold it up. It's a suspensory type of ligament, and it's part skeletal muscle, part smooth muscle. That's really fascinating because this ligament is only partially ligamentous. It can actually contract a little bit, and it'll do so in order to induce the passage of food down the jejunum, because when you pull it up, it'll kind of increase that angle of the small intestine, and so food just kind of drops down a chute whenever that ligament of Treitz contracts. And then you have an ileum, which has Peyer's patches all throughout it, and that's how you distinguish it histologically. The general structure of all the GI tract, you have a tunica, mucosa, you have a mucosal layer, then you have a submucosal layer, you have a proper muscular layer, which is typically 2 layers of smooth muscle, circular on the inside, longitudinal on the outside. And then you have a serosa encasing your intraperitoneal organs. And if it's a retroperitoneal organ, it'll have an adventitia. So this SDL does give you a good primer on different types of epithelial cells you encounter in the small intestines, primarily the enterocyte, which is your functional absorptive cell. It's a tall columnar cell with a correspondingly columnar nucleus. Fairly eosinophilic, not much to see there. You're going to recognize it by its brush border. You also see goblet cells atop the mucosal layer of the epithelium of the gut. You should know what goblet cells look like by now. It's important to note that these outermost membranous cells of the gut have a short shelf life, and they're constantly replenished by stem cells that reside deep in the crypts of the intestine. In the small intestine, we call them the crypts of Lieberkühn. So because these absorptive and goblet cells have a short shelf life, you need to know that if your patient hasn't eaten in a few days, patient hasn't eaten in 5 days to a week or so, you've got to refeed them very slowly because they don't have the absorptive capacity to handle a large influx of nutrients at one time, and that could lead to a lot of GI upset. So if you have ever, like me, wondered what types of cells are in the crypts of Lieberkühn, who is this Lieberkühn dude anyway? Well, this SDL does summarize that as well. You have Paneth cells, which are defensive cells that contain eosinophilic granules, and they can degranulate in order to kill pathogens. You also have M cells, microfold cells or M cells, and they are kind of a shuttle or a transport station, and they will uptake antigens from the lumen and present them to lymphoid follicles, and you will always find M cells atop lymphoid follicles. So there's a particular type of bacteria that likes to infect M cells. Can you think what that is? That would be Shigella. And then finally, deep down in your crypts of Lieberkühn, you also have stem cells, and those are the ones that will replenish your goblet cells and enterocytes naturally, a 5 to 6 day process. Lymphocytes are ever prevalent throughout the small intestine. Again, they're most concentrated in the Peyer's patches of the ileum, but they multiply in Peyer's patches and disperse throughout the length of the entire small gut. Some distinctive characteristics: the duodenum has Brunner's glands in the submucosa, and it's got a lot of them, and you're going to know when you're looking at Brunner's glands. Peyer's patches, again, in the ileum, have a dome structure. They're spherical, and they are, again, lined by M cells. So getting into malabsorption, talking generally, it's characterized by diarrhea and or steatorrhea, which would be fat in the stool. Other common symptoms include abdominal pain, weight loss in adults, and failure to thrive in children. Malabsorption means you're not trafficking nutrients into your body properly. And so the process of trafficking nutrients into your body kind of has 3 stages. You could look at it like that. It's got the luminal phase, in which enzymes work on food while it's in the middle of your gut, not in your body yet. Then you have the mucosal phase, and you can think of this as everything going on inside the enterocyte. And then you have the post-absorptive phase, and what all these have in common is the post-absorptive phase describes after food has entered the enterocyte and it's gone out the enterocyte. Well, you could still have malabsorption if you have a lymphatic obstruction, because you know that all of the fat that you uptake from your gut has to go through the lymphatics before it gets dumped out into the subclavian veins and enters your bloodstream. So looking at this chart, you essentially have any luminal phase defect is pre-enterocyte, and any post-absorptive defect is post-enterocyte. So everything mucosal phase, that's talking about problems that are going on. The problem is due to poor enterocyte function. Now, the luminal phase defects are not talked about too much in this SDL, but they're still very important to note. Pancreatitis is an important disease to recognize. It can turn acute pretty quickly. And then liver disease is pretty common, and bile duct diseases also. Remember that you need pancreatic enzymes. You really need them to digest protein, large proteins, into edible bits for enterocytes. And we like to absorb di and tripeptides. We can absorb those, some oligopeptides, but big proteins, no, we can't traffic those into our cells. So you need proteases. And you also need bile salts produced by the gallbladder, and the liver, well, produced by the liver and stored in the gallbladder, so that you can pick apart fat bit by bit and turn it into a micelle so that it can diffuse through the mucus layer of the gut to the enterocyte surface. Because if you don't have micelles, which are hydrophilic on the outside with a hydrophobic lipid core, if those fats aren't packaged in a hydrophilic container, they're not going to be able to diffuse through the aqueous mucus layer lining the gut and get to enterocytes. The micelle facilitates that, and once the micelle hits an enterocyte, that's just simple diffusion after that. So what you need to know about luminal phase defects is that alcoholism is a very common predisposing factor to liver injury and to pancreatic injury. So that's the biggest possible pathology in my mind that could get tested on this exam upcoming. Post-absorptive phase defects, you take a look at all these. Intestinal lymphangiectasia. You know, it's going to be like a vascular lymphatic malformation leading to reduced flow through the lymphatic system. Lymphoma, metastatic carcinoma, and metastatic neuroendocrine tumors. You might be wondering, how does that cause a post-absorptive phase defect? And to my knowledge, the answer would be, well, those things can compress your lymphatics and lead to a sort of minor obstruction of your lymphatics, creating fat malabsorption that, if chronic, you might get, again, hypovitaminosis of a fat-soluble vitamin. Now, all these mucosal phase defects, that's what this SDL is focusing on. Thinking about the clinical presentation of malabsorption, we're going to classify it based on whether it's malabsorption of a single nutrient. You know, you might have an iron deficiency anemia. That's a partial malabsorption. Although that might not be a malabsorption, you get it. A global malabsorption, however, is going to be you are having a very tough time trafficking many nutrients into your body. We're talking carbs, we're talking fats, we're talking proteins, we're talking vitamins and minerals. And the reason for that is typically because you've got some gastrointestinal pathology that is eroding the villi, the absorptive surface of your small intestine, and causing an inflammation that incapacitates the function of the enterocytes within. So symptoms associated with global malabsorption are going to be diarrhea number 1, steatorrhea number 1B, and then bloating and flatulence is more minor symptoms. We said in adults, you get weight loss. In children, you get failure to thrive. So that's the question stem right there. So you are going to see some lab tests in the question stem too, and you are going to want to know what those different lab tests are specifically looking for and what they're trying to assess. You want to know the gold standard for testing for fat malabsorption is quantitative stool analysis for fecal fat. So you put it in a bottle and send it to the lab, and they're going to look at it, and measure, quantify the amount of fat in the stool. You can also qualitatively do so by Sudan staining feces, although I don't know why anyone would ever want to do that. Let the machine take care of that. So fat malabsorption is quite common. Carbohydrate malabsorption is assessed by the D-xylose test, which essentially, if you give someone xylose, they should absorb all of it. And if they have a compromised small intestine, then they're not going to absorb all of it. So you give them a measured amount, and then you measure their urine or their blood and see how much is in there. And if it's lower than you would expect, then you're going to be thinking this is a small bowel pathology. And some top 3 on that differential is going to be small bowel bacterial overgrowth, celiac disease, and Whipple's disease. And we're going to talk about all 3 of those today. You can also give someone a lactose tolerance test, although I feel you would only do this if you were, number 1, suspecting lactose deficiency, or number 2, if the patient has an active current bowel infection, such as a rotavirus infection, something you know is going to be attacking enterocytes, and you just want to see if they are lactose tolerant. The hydrogen breath test works because colonic bacteria ferment carbohydrates to form hydrogen gas. So this is a good proxy for how much bacteria is in your small intestine. And indeed, small intestinal bacterial overgrowth is going to be our most common application of this test. Now, normally most of your intestinal bacteria is in your large intestine, in your colon, and that's where it produces a lot of gas. But if a patient's particularly gaseous, it might be because that bacteria has crept up proximally to the small intestine. And so what we are talking about when we say that bacteria metabolize sugars and fatty acids down into hydrogen, I found a good chart that explains that. If you look at what Shigella is doing right here, it gives you an example. Shigella is going to take pyruvic acid, metabolize it down to formic acid, and then split that formic acid, which is like formaldehyde essentially, into carbon dioxide and hydrogen gas. So all these different bacteria are fermenting. They're taking these small carbon molecules and small fats, and they're breaking them down to smaller and smaller pieces through some condensations and dehydrations. And generally, they're popping out hydrogen at the end of that. So the hydrogen gas and the carbon dioxide as well, associated with bacterial metabolism, is often the cause of gas. Protein malabsorption can be assessed by looking for alpha-1 antitrypsin activity. I don't know too much about that. I just am going to remember that. And then pancreatic exocrine insufficiency, our gold standard test for that is fecal elastase. Although there's a lot of enzymes secreted by the pancreas, and sometimes you might have to look for a specific one. So now we're going to talk about celiac disease. What's going on in celiac disease is an autoimmunity against a specific protein expressed within enterocytes of small intestinal villi, and the antibodies against this self-antigen will trigger an immune response, causing villus destruction. Anytime the patient eats gluten, the immune cells in that area are going to pop off against this tissue transglutaminase enzyme. So celiac disease is the most common malabsorption syndrome by far and away. It's very prevalent, and many cases do go undiagnosed. It's got a bimodal age distribution, meaning that we do catch a lot of these in year 1 or 2, and then many adults present with celiac disease. So I don't want you to think that just because it's autoimmune, that means we catch it early. Now, gliadin is a breakdown product of gluten, and gluten is a protein that's present in grains and breads. Now, we know now that tissue transglutaminase is the major autoantigen of celiac disease, but that's a pretty recent finding. Before, we were doing all these screenings for anti-gluten, anti-gliadin antibodies, this IgA anti-endomysial antibody. Those were the sort of things that we would look for in the blood to confirm celiac disease before we really understood that TTG is what's causing it. And TTG basically gets presented on MHC type 2 molecules to T cells. And when T cells recognize this antigen, they'll attack the cells expressing TTG. And there's a lot about the enzymes and the approach to diagnosing celiac based on enzymes at the bottom of page 5 here. You can read up on that if you want. What I'm focusing on is that the ELISA assay for IgA antibodies against tissue transglutaminase is our gold standard diagnosis. So if they give you a presentation of celiac and they say, what test would you like to order? ELISA for TTG IgA. Now, there's an HLA haplotype or 2 that gives you a predisposition to gluten. That's going to be DR3DQ2 and DR4DQ8. And the mnemonic I've heard for that is I ate too much Dairy Queen. That's DQ, 2, and 8. So celiac disease is an iceberg disease. And when we say that, we're referring to the epidemiology of the disease, the mapping out of it. The majority of people with celiac do go undiagnosed. How does celiac present? Well, symptoms common of malabsorptive disorders, diarrhea, steatorrhea, but particular to celiac is that symptoms present around the introduction of grains, breads, and cereals into the diet. You might see some extra intestinal symptoms in celiac disease, anemia due to impaired iron or folate absorption, a bleeding diathesis, and a diathesis is just a predisposition to something. So a bleeding diathesis means you're predisposed to bleed a lot due to impaired vitamin K absorption. Osteoporosis, that's our loss of vitamin D. Hypocalcemia should make sense too. But the most particular finding to celiac disease is this rash called dermatitis herpetiformis. And it's described as a pruritic papulovesicular skin lesion involving extensor surfaces of the extremities, trunk, butt, scalp, and neck. So you're going to see this in a minority of patients with celiac disease. However, all patients with dermatitis herpetiformis have celiac disease. So you want to visually recognize this in case it gets thrown at you. Here's what's going on with that papulovesicular rash. Here it is on the trunk. And man, that is a wide margin. Here it is on the extensor surfaces. And then this upper right corner photo here. Let me blow that up for you. Really shows you the vesicular component of it. I mean, it's vesicular in the same way that herpes is vesicular. And it's caused by fluid edema due to the splitting of epithelial cells. They rip apart from one another. Some fluid gets in between them. It's termed acantholysis, and that leads to the vesicular appearance of this dermatitis herpetiformis, which is totally indicative of celiac disease. So you've got a patient who you suspect celiac in. What kind of blood work do you want? Well, you want to monitor their electrolytes and their macros, basically, to make sure that they're absorbing everything that they should be, that there are no dietary deficiencies. Quantitative fecal fat analysis, #1 test for malabsorption. For celiac specifically, tissue transglutaminase IgA antibody. And IgA, that makes sense because that's associated with mucosal surfaces, particularly your gut and your pharyngeal tonsils. And IgA is a dimer, and it's soluble. And because it's soluble, you can push it out into the lumen, and it will bind to antigens while they're still in the lumen before they get into your body. So the fact that it's an IgA antibody makes a whole lot of sense. Endoscopy, you might see this in a question stem. I don't think you're going to get asked to make this diagnosis based on endoscopy alone because it's really hard to tell the difference. You might see it in words in a question stem as reduced, absent, flat duodenal folds. They might say vasculature, hypervasculature in the duodenum. And what both those findings are telling you is that there's atrophy of the gut mucosa in that stretch. Let's talk about the pathology of celiac disease. Villus atrophy is the name of the game. And in response to that villus atrophy, your glands are going to get bigger and bigger and bigger to try to soothe the inflammation as much as possible by pumping out secretions. So when we say villus atrophy, a more simplified way of thinking about that is just a flattening of the microsurface of the gut, not just the macro surface. And what we'll also see on histology is an increase in the cellularity of the lamina propria. And the lamina propria, of course, is that connective layer right underneath the epithelium and right above the muscularis mucosa. So let's take a look at some celiac histology quickly because you're going to have to differentiate it from Whipple's disease. This is what we're talking about when we say a flat gut and villus atrophy. You know, normally the small intestine has a bunch of villi sticking out of it, kind of like fingers or so, like out of the floor of the gut. And so you don't see any of these there. It's a totally flat surface. And when we're looking at this bottom left photo, the apical curvature of that is what should be the lumen of the gut, not the base of the gut, right? That's so flat you could mistake it as the base of the gut, right? And then again, hypercellularity in the lamina propria, check. Same thing that we're looking at here on the right, just a little bit more zoomed in. Hypercellularity is definitely there of the lamina propria. Highlight some of that in yellow here. Right there, just a ton of immune cells. And again, a lot of those are going to be T cells drawn to enterocytes in that tissue, transglutaminase, IgA. B cells are involved too. I mean, it's an IgA, but the IgA can activate T cells as well. Here's a good look compared to a normal gut. Normal on the left, celiac on the right. And so, bang, big finger. Another big finger. But we look over at celiac and it's like small nub, small nub, small nub. And hypercellularity again, all throughout that lamina propria. So that's the histology of celiac disease. If you see a gut with celiac disease, and especially if they tell you it's the small intestine, you're going to say, oh, wow, I bet they're not absorbing very much at all from their diet. And there's really one big differential you're going to have to make in this SDL, and that's Whipple disease again. And not many others of these malabsorptive pathologies have a lot of histology described in this text. So wrapping up celiac disease, how do you treat it? Don't eat gluten. Can't drink beer, but you can have liquor, white liquor. Complications, two big ones: enteropathy-associated T-cell lymphoma and small intestinal adenocarcinoma. Increased incidences. I know we've seen that enteropathy-associated T-cell lymphoma in a prior SDL. I'm totally blanking on it right now, but go back and brush up on it, as I shall. Environmental enteric dysfunction. Next, don't say nothing about that. Tropical sprue. This one sounds like a new flavor of Capri Sun or something, you know, like tropical sprue. Tropical sprue. Well, how do you define tropics? Great question. Thankfully, Arvin Santo knows that the tropics are 30 degrees north and south of the equator. So travelers and indigenous natives of this stretch of the globe are prone to get tropical sprue, which is an infection of the upper small intestine, producing enterocyte injury and overgrowth of gram-negative, I think that should say anaerobic bacilli. Might be aerobic, I don't know. I'll Google it and report back. So then The bacteria produce toxins which snowball small bowel damage and result in malabsorption. So this is going to be a mucosal phase defect because absorption is being hampered directly at the level of the villus, specifically at the level of the enterocyte. Enterocytes are getting knocked off. So I see this more so as a gateway to a micro question or to a nutrition question on boards rather than just, oh, do you know that this is tropical sprue? Because there's a lot of different ways you can get it, it seems. So the histological changes are similar to celiac disease, but total villus atrophy is uncommon. And again, if it's celiac, you're going to know it's celiac because of the questions, Tim. They're not going to make you guess. So any stem involving tropical sprue is going to describe a patient with chronic diarrhea, maybe steatorrhea. So you'll get the quantitative fat analysis back for that. And then nutrient malabsorption, you might get an ion panel or something, who has lived for more than 1 month in an area where tropical sprue exists. Diarrhea can first develop after a patient returns from the tropics. And what's a big complication? Vitamin B12 deficiency in chronic cases. We know that that's going to present with macrocytic megaloblastic anemia along with some dorsolateral column degeneration. Treatment with tetracycline and doxycycline is a good call. That's gut active. Goes after gram negatives and gram positives. Broad spectrum. Prognosis is good. Autoimmune enteropathy. What you're going to want to study from this section are these two Johns called IPEX and Apecid, Apecid, APECED. Let's go with that. So those are the need to know ones. And autoimmune enteropathy is a disease of infancy, disease of children, characterized by intractable diarrhea. You just cannot stop using the bathroom. And you're going to see antibodies directed against enterocytes. So again, going back up, this is that mucosal phase defect. Remember, we said luminal phase, pre-enterocyte, post-absorptive phase, post-enterocyte, mucosal phase, stuff that hurts the enterocyte. It's going back down, autoimmune enteropathy. You've got antibodies directly against enterocytes, leading to lymphocytic inflammation in the lamina propria, increased CRIP apoptotic bodies, and a relative decrease of intraepithelial lymphocytosis. So what does that mean? Normally, you see a row of enterocytes in the gut, and there will be a lot of lymphocytes just dotted in between enterocytes. And so I figure that you're not seeing them here because, I mean, it's like they've already killed all the enterocytes that they're reacting against, you know, so it's like they have no reason to be there. And plus the T cells have to talk to the B cells to get antigen and other antigen presenting cells. So they got to migrate out of the gut sometimes. And so that's my best guess at that. Clinically, what do you see? Diarrhea, steatorrhea, surprise, severe weight loss, failure to thrive, especially because it's an infant disease. And these two systemic forms, those are going to be what you want to go back and study. So IPEX stands for immune dysregulation, polyendocrinopathy, enteropathy, X linkage. Ton of associations, big symptoms that are going to let you know that from APECED. So IPEX is characterized by thrombocytopenia and neutropenia. Low platelet counts, low white blood cell counts. And then a myriad of different systemic diseases that may present alongside it. So I'm straight up going to make flashcards for those. I encourage you to do the same because reading it is kind of useless. It is due to a FOXP3 gene mutation that is going to hamper CD4 positive Treg cells, regulatory T cells. So that could be a question that gets thrown out of there. Three questions really from that. What's the gene? What's the mechanism, CD4 T cells, and what's the associated condition? And then one of those there is going to be the correct answer. And then Apecid is an autosomal recessive disease, and it stands for autoimmune polyendocrinopathy, candidiasis, and ectodermal dysplasia. So if you remember, the C stands for candidiasis, refractory candida. Where are you going to get that? Probably the mouth. If you're a chick, you're going to get it in the vagina. You can get it in the esophagus if you're immunocompromised. And then you're going to have endocrinopathy in both of these. And then various associated autoimmune disorders with that one as well. So again, I'm going to flashcard those. I hope you do too. Let's talk about lactase deficiency. So lactase is also called disaccharidase, and it might be referred to in a question stem as that or as just brush border enzyme, because it is localized to the luminal surface of enterocytes where the brush border is. So you have a lot of lactase there, and it splits down lactase into glucose and galactose. That might be a question, a gimme. You can inherit a lactase deficiency, and if you do, it's autosomal recessive through the LTC gene. Or you can acquire a lactase deficiency if there's enough damage to the gut. And a lot of different pathogens can cause this. Most common bacteria is going to be E. coli. Giardia can cause a lactase deficiency. Vibrio can cause some irritation to your enterocytes, give you a lactase deficiency. Rotavirus give you lactase deficiency. What do these things all have in common? They're going to give you diarrhea. They're going to make you poop, and they're going to make you shed that enterocyte lining. Remember, that gets replenished every 5 to 6 days. Well, if you have a lot of diarrhea going through all at once, well, then those cells get pulled off and sloughed off, and it might take a while for them to recover. And so the fact that you don't have a lot of enterocytes lining your gut is going to lead to this lactase deficiency. So if it's acquired, it'll go away, but you still might want to test for it anyways, just so that you know, hey, don't give this patient any milk, you know, common hospital food. And finally, lactose malabsorption. If the patient does eat lactose, drink lactose, then the lactose can't go into the body, so it's going to stay in the gut, and it's going to act as an osmotic cathartic, which is basically a solute that pulls water from the body into the gut and just increases the fluid mass of stool. Let's discuss now Abetalipoproteinemia. This is a problem with the microsomal triglyceride transport protein. And what's going on in Abetalipoproteinemia is you're totally unable to import fats into the body from enterocytes. So you can get fats into enterocytes because that's just simple diffusion. And there's nothing wrong with your bile acids as long as you're synthesizing enough de novo, because you can do that for cholesterol and bile acids. But you can't make the transport protein that puts them onto that ApoB48 protein, right? Because that's what your gut makes. Your liver makes ApoB100. Your gut makes ApoB48. That ApoB48 goes into lymphatics and it pops out in the blood. And then now you got a chylomicron. So clinical findings in Abetalipoproteinemia presents very, very early: steatorrhea and diarrhea. No surprise. Failure to thrive. No surprise. However, lab findings characteristic include very low serum cholesterol, under 50, 45, and totally undetectable LDL. Hypovitaminosis E is the most common vitamin deficiency in Abetalipoproteinemia. And as we saw earlier, you'll see acanthocytes that represent the dissolution of red blood cell membranes, and this can potentially lead to a hemolytic anemia. So amongst other things, you got to supplement vitamin E. Microvillus inclusion disease, pretty cool because it tells you exactly what it is. If you look at microvilli, you see inclusion bodies in the single constituent enterocytes of those microvilli. And the inclusion bodies that you see in enterocytes in MVID are full of endosomes containing brush border enzymes that should be popped out of the enterocyte but can't be because they're not trafficked properly, because you're missing this myosin 5B gene. Electron microscopy is a common technique for identifying inclusion diseases. Think back to things like Gaucher, Hunter's, Hurler's, Tay-Sachs, Niemann-Pick. And you can also immunostain to try to catch those inclusion bodies for villain or for CD10. And again, those are brush border proteins that normally get popped out of enterocytes, but you can't pop them out because you're kind of missing the oomph in that pop out. You can't traffic them to the membrane to begin with. Whipple disease. This is the one you got to differentiate from celiac because it looks very similar until you train your eye a bit, and then you're gonna recognize it every single time you see it. It's characterized by PAS positive macrophages inside flat villi. So that flat villi it has in common with celiac. This is caused by a gram-positive rod, Trophorema whipple, which is part of the family Actinomycetes. Disease is common in farmers and those exposed to soil and animals. It's pretty rare. Most patients are male. Patient's immune system incorporates Trophorema whipple into tissue macrophages, which infiltrate various tissues. And so then they particularly go in the gut. And if you look at the gut, you see macrophages filled with these intracellular organisms that will not gram stain. I think I might have, well, yeah, these are gram positive. So they'll gram stain, but not when they're in macrophages. Capiche? So you got to hit them with the PAS. Electron microscopy is diagnostic. Here's a picture in black and white of flat, blunt villi with foamy macrophages. The macrophages are picking up PAS there. So if you want to look at it in color, that's where the foam macrophages are. Now let's take a look at this in living color. So first time I saw this, I was like, oh, geez, that does look just like celiac. But I looked at it for like 10 seconds more, and then I was like, oh, there are the macrophages. So let's find them. Right there. Oh, man, that's nothing but macrophages right there. You see that? This right here is nothing but foamy macrophages. And this is what they look like. Again, once you get used to seeing them, you can't unsee them because you don't see any cells that look like this in the gut. They're kind of shaped like parietal cells are in the stomach in that they're big and round, and they've got a foamy pink cytoplasm with big round nuclei. Oh, man, yeah, tons of them. Look at them. And closer you get, the better you can see, yeah, those things are foamy. Last slide. Here's what they look like with the PAS stain. I think this might be the same picture in the SDL, actually. And then in the lower right, yeah, they pick that purple PAS up like it's nothing. So just because you see foamy macrophages inside the small intestine does not mean that you have a T. whipple infection. It may also be Mycobacterium avium intracellulare, which happens to also hide in macrophages and also happens to stain PAS positive. So in the case of a MAI infection, you got to acid fast stain it. But MAI is really rare unless it's an immunocompromised patient. So you're probably thinking T. whipple until proven otherwise. Clinically, finally, something that's not just diarrhea. So you get arthritis and arthralgias first, number one. And then you've got a long time span, and then you start seeing GI symptoms. That makes Whipple's disease very unique amongst all these other malabsorptive pathologies. But when it presents in the GI tract, same old diarrhea, weight loss, lymphadenopathy, muscle wasting, anemia and vitamin deficiencies. And Most recent article I could find says treat this with doxycycline and hydroxychloroquine. So that's it for our malabsorption. There's a lot more that goes into malabsorption than that, you know, and there's a lot more causes of malabsorption. And of course, the ramification of deficiencies of different micronutrients and macronutrients are multiple. And so you could get tested on not only what's in this text, but what happens if you're missing X, Y, or Z. So head on a swivel and keep studying. Now let's transition into talking about diverticular disease of the colon. I think about a diverticular disease, a diverticulosis. A diverticulum to me is just an aneurysm of the gut. And that's a gross oversimplification, and that's not what it is, but it's analogous, dang it. And so I think of it as an aneurysm at sites of preferential weakness where blood vessels penetrate the smooth muscle of the large intestine. And that's exactly what the text says at the bottom of page 10. Diverticula develop through herniation of colonic mucosa and submucosa, through defects in the tunica muscularis at the weakest point in the colonic wall, the sites where the vasa recta penetrate the tunica muscularis. So you've got a weak wall. It's naturally weak. Nothing happened to make it weak. It's just this is the weakest point in the wall, okay? And it's weak because there's a blood vessel going through the wall. So the wall had to open up to let the blood vessel through. And so around the margins of where that vessel penetrates that wall, structurally compromised. Most patients with diverticulosis, which is a bunch of diverticula, one diverticulum, you have a lot that's diverticulosis. Most patients are asymptomatic. Now, if you get symptomatic, you call it diverticular disease. That just means you have a symptomatic collection of diverticulum. Diverticulitis is a complication of diverticulosis. I want you to understand that. First, you have diverticulosis. Then you could get diverticulitis, or you could just live your whole life with diverticular disease and never get diverticulitis. Diverticulitis is inflammation of diverticula with related complications, and they are supernumerary. Acute diverticulitis is the most common complication of diverticular disease. So back to the pathology. Again, I compared this to an aneurysm, and due to the structural defect, I want you to reference back in your mind to when you learned about the brain. And when you learned about the circle of Willis, you realized that there was this junction of the internal carotid going up and hitting the middle cerebral artery. And at that angle, that's where like 40+% of baryaneurysms occur. And they occur there because the wall is structurally weak there, because you just don't have a tunica media in that area. It's very thin. And I don't either. And nobody does, you know, it's just built into human anatomy that we've got a flexible spot of vasculature there so that the force of flow coming up from the artery below and hitting it can rebound off that wall. We don't want it to be non-compliant. So because we have a weakness there, we tend to get aneurysms there. Same exact thing is happening inside your colon where these diverticular pouches develop. And in the colon, the area of weakness is at sites of penetration of the vasa recta, which remember, well, vasa, what does that mean? Blood vessel. Remember, vasa vasorum is the blood vessel that supplies your aorta. So recta, what's that mean? You can figure that one out. 90% of patients have sigmoid colon involvement. And so I assume that's because this is where the vasa recta is the most abundant. Etiology and pathogenesis. A low consumption of dietary fiber leads to a low stool mass and consequently a reduction in lumen size. This may result in transmission of muscular contraction force to the colon wall rather than to the lumen contents. So how I visualize this is, you know, a contraction is a contraction. And when your brain tells your gut to squeeze, your gut's going to squeeze with the same force every time. And it doesn't matter if it's curling a 50-pound dumbbell or a 20-pound dumbbell, it's going to fire that muscle with the same force. So if you are
contracting your gut and there's nothing there. Let's say you just ate nothing but Jello for a week, you know, your large bowel is just going to be like, it's going to be slamming that stuff, you know, like, and then, well, what's going to happen? Well, because there's no pushback, it's just going to be slamming into itself, right? And so that hurts the wall of your gut, and that can lead to high pressures, which can lead to ischemia and strain, wall strain. And so that leads to perforation and necrosis in this area of natural weakness, the vasorectum. So another risk factor, high intake of red or processed meat. You know, I mean, I'm prone to say just processed meat, maybe like red meat if you're having it on like a burger bun with French fries and ketchup. Like, yeah, you know, if you're having like 10% protein and 90% junk, then yeah, it's probably linked to red meat. But like processed meat, I can buy that. So what do you need to know about the presentation of diverticular disease? Well, it's the #1 most common cause of hematochezia, which is bright red blood in the stool, as opposed to melena, which would be occult blood. Diverticular disease, what I got out of that paragraph there is that you're not going to see that presented to you in a question, really. You're not going to see asymptomatic diverticulosis in a question unless they are just really trying to gift you a question, you know, like the type of question that you're doing it and you're like, oh, 95% of students got this one right. Oh, I feel smart. Like that would be if they asked you about plain diverticulosis. No, they're going to ask you about the complications of diverticular disease because there's a lot and they can approach it from many, many angles. So diverticulitis, most common complication. What's a complication of diverticulitis? Abscess, hemorrhage, perforation leading to peritonitis, possibly strictures, which is going to be like a reactive scarring of the bowel that's going to tighten it up because a zone or a segment, a stretch of scarred bowel can't expand and contract like it should. So that's a stricture, and we've seen that in the esophagus before. Fistulas, that's a tunnel, communication between one part of the bowel and another, or a part of the bowel and a different organ. And then finally, small bowel obstruction. So yeah, like I said, that's a lot of angles, and we'll go through them one by one. Diverticular bleeding typically occurs in the absence of diverticulitis. So if there's one thing that is associated with diverticular disease and not the itis, it is hematochezia. Acute diverticulitis, how does it present? It feels like appendicitis. You've got point tenderness, you've got guarding, you've got rebound tenderness, and it's on the left side of the body, not the right, because this is occurring again at the sigmoid colon 9 times out of 10. Acute diverticulitis is accompanied by infection, most commonly E. coli, Bacteroides fragilis. So this could be just a gateway to a micro question. Lower left quadrant pain. Pain is usually constant and often present for several days. Patients may also have fever and leukocytosis indicating acute bacterial infection. Good picture of what diverticuli look like. So they're going out of the colon and not in to the colon lumen. And so you got to really look twice to make sure you're not looking at a polyp, right? And here's what they look like on the outside. And I don't know, there's something weirdly beautiful about that image. So perforation can, of course, happen because if this thing, well, an aneurysm can pop, so a diverticulum can pop, of course. And that can lead to a generalized peritonitis as the contents of the bowel spill into the peritoneum. We've got a whole other SDL on that. And what you're going to see clinically is going to be, again, tenderness, guarding, involuntary guarding, rigid abdomen, or possibly absent bowel sounds. You can get a small bowel obstruction from diverticulitis as, well, that's a great question. I wonder how you do get small bowel obstruction from that. I don't know. It doesn't say, but you can. And then finally, fistula might form from a ruptured diverticulum, or possibly from a diverticulum that just grows so much that it just starts to synapse with an adjacent organ. And If you get one of these between the bowel and the bladder, okay, that's called a colovesical fistula. And how that presents is pneumaturia and fecal urea. You know what those mean? Fecal urea. And pneumaturia, it's like, well, okay, you're just standing there and you're pissing, and then it just stops. And you're like, whoa, but like you're still pissing, right? But you're pissing out air. And then you just start pissing again. So that's pneumaturia. So the fistula itself is just a tunnel connecting the colon to the bladder again. And can that rupture? Absolutely. And that's, again, going to give you peritonitis and probably a fat UTI as well. Lab findings, again, leukocytosis and left shift indicating acute infection. CT is the test of choice. Barium edema might reveal the presence of diverticula, but cannot discern their clinical relevance. Makes sense. So 15% of patients have an associated complication. Majority of patients have no complications. Which type of patient do you think you're going to see in a question? Let us now discuss angiodysplasia and hemorrhoids. So angiodysplasia is the #2 most common cause of hematochezia behind diverticulosis, diverticular disease. Defined as the finding of flat cherry red lesions 1 centimeter in diameter, consisting of abnormal, ectatic, dilated, tortuous, and usually small blood vessels on endoscopy. Histologically, the affected vessels are in the mucosal and submucosal layers of the gut lined by endothelium with little or no smooth muscle. They are anatomically similar to telangiectasias. However, telangiectasias are usually referred to in the context of systemic or congenital diseases. I remember you can get telangiectasias as part of Crest syndrome, which is going to be diffuse scleroderma. And you can also be born with a telangiectatic lesion, right? And so that's going to be dilation of a blood vessel. They're typically dermatologically encountered. Angiodysplasia is what we call the GI variant of that same similar phenomenon. Again, tortuous dilation of vessels because of high flow. Somehow there's a backup, there's a buildup of pressure inside a blood vessel. It dilates and you have the risk of rupture, or especially if it's in a vein, of thrombus. Most angiodysplasias occur in the cecum and in the ascending colon. So that's the other side of the bowel that we're, compared to what we were just talking about. We said diverticular disease affects the sigmoid colon, that's lower left quadrant, but the cecum, that's right lower quadrant. So the reason why you find these vascular malformations and bleeds in the ascending colon has to do with the fact that these blood vessels that run through the wall of the gut are constantly getting squeezed by the circular and longitudinal muscles surrounding them. Now, it just so happens that the right side of your gut squeezes harder than the left side of your gut. So when it squeezes, as this wonderful cartoon on the right side of page 13 illustrates, it compresses veins, leading to backflow, high hydrostatic pressure in the capillary bed. You get some diffuse bleeding into the epithelial layer, the mucosal layer. Now, why does your ascending colon squeeze harder than your descending colon? Well, it's got to push poop against gravity. That's why. So it's got a bigger diameter in order to generate more pressures and squeeze with more muscle fibers. Pathogenesis, saying what we just said. Angiodysplasia develops due to recurrent low-grade obstruction of submucosal veins at the level of the muscularis propria, your circular and longitudinal layers. Drainage is intermittently obstructed by muscular contraction or increased intraluminal pressure. Angiodysplasia most often occurs in the right colon where wall tension is highest. Again, it's got to push up against gravity.
Angiodysplasia is more common in patients with aortic stenosis, von Willebrand disease, and chronic renal failure. That's a possible question right there. So 2 questions right there. What is it? What does it present alongside? That's what they can really ask you about angiodysplasia. Hemorrhoidal disease, you've got internal hemorrhoids and external hemorrhoids. And then you've got one real differential, which is rectal varicose veins. And I believe that rectal varicosities varices are fair game for this test because they're brought up, and again, they are part of the differential for hemorrhoids. So what is a hemorrhoid? It's an abnormally dilated and inflamed vein. It's a vein in the wall of the anus and the rectum. And the big risks associated with venous damage, as we just saw in angiodysplasia, are going to be number 1, bleeding if the pressure builds up in there, and then number 2, thrombosis, because veins are prone to stasis, especially venous plexi. So you've got this anatomical locality called the hemorrhoidal plexus. I kid you not, that's what they're calling it in this SDL. Now, if I wrote it, I'd call it the rectal venous plexus just because, but the hemorrhoidal plexus, okay, very descriptive. Drains into the superior and inferior rectal veins. Now, your rectum is supplied. Wonder if I still got this picture in here. Yeah, here we go. So here's a good look at the anal canal, and here's the inferior rectal artery, and then this up here would be the superior rectal artery. We'll put superior in green, and we'll trace its pathway down. And you can tell that the superior rectal artery does not supply all of the rectum. And then we'll go from the bottom in yellow and look at the distribution of the inferior rectal artery. And again, you can tell the inferior rectal artery does not supply all of the rectum. So in between the distributions of these 2 arteries, you have this thing called the pectinate or dentate line, which I've illustrated in blue. And the difference between internal and external hemorrhoids is where they sit relative to this line, where they originate, namely because they can prolapse. Internal hemorrhoids originate above the dentate line. External hemorrhoids originate below the dentate line. So external hemorrhoids are lined with a modified squamous epithelium. Internal hemorrhoids are covered by columnar epithelium. Possible question. How do these things form? Well, my first thought was, oh, venous plexus, cirrhosis, you know, same thing as esophageal varices, but no. That is not how you get a hemorrhoid. There's a separate pathology called rectal varices that you can acquire, you know, through traditional methods, high hydrostatic pressure mediated by backup of the portal vein mediated by cirrhosis. But that's not what's going on in a hemorrhoid. In a hemorrhoid, you see prolapse of this venous tissue, be it the superior, inferior, right, into the lumen of the rectum or directly off the skin of the rectum due to the degradation of the supportive tissue around it. So it's anchored into place, but something happens to compromise that anchoring, that glue. If you've ever had something heavy just fall off of your wall, right, and you had it on like command hooks or like one of those like dumb little tack strips, if you've ever had something like that happen, like that's a hemorrhoid. So internal hemorrhoids arise from these structures called hemorrhoidal cushions. And you've got 3 of them. You've got a left lateral, a right posterior, and a right anterior, and they're essentially just 3 small venous plexuses. What causes them to prolapse outward and fall down?
What causes that surrounding tissue to become weak? Possibly straining and increased intra-abdominal pressure that might occur with coughing, sneezing, or Valsalva maneuver. So the cushions fill with blood, they get heavier, they exert more of a pull, more of a force on the surrounding connective tissue, and eventually, due to that enlargement, they're going to fall out and displace distally. We think that a big risk factor leading to hemorrhoids is lack of dietary fiber, and then all the other risk factors in this paragraph make a whole lot of sense to me. Or they're at least the type of things that you would guess on a test. Hemorrhoids consist of thin-walled, enormously dilated submucosal vessels. Again, they're veins, and they're going to be dilated because there's a lot of blood in them that's pooling there because, well, the vein can't squeeze that blood back up, you know, quite nearly as well as an artery can squeeze blood. And so due to that thin venous wall, the blood just kind of pools there. One complication includes superficial ulceration, possibly a rupture of the submucosal smooth muscle surrounding the anus. It's a great, great graphic to look at and learn on your own. I won't explain it to you. Here at the bottom of page 15 is what I was mentioning. Hemorrhoids are not rectal varices. You do get varices by high hydrostatic pressure in cases of portal hypertension, but that's not how you get hemorrhoids. You might confuse varices with hemorrhoids, but unlike hemorrhoids, varices are located above the level of even internal hemorrhoids in the rectum near the first rectal valve, about 4 centimeters above the dentate line. So around here is about where that last rectal valve is. And so there's your dentate line right there. And so we're thinking external hemorrhoid is going to happen out here. Internal is going to be happening right up in here. And then a rectal varice, that's about where it would occur. So that's your anatomical differential. Now, basically this last page, page 16, you could just review this one page and it'll tell you everything you need to know to answer a question about hemorrhoids. It reminds you that internal hemorrhoids are above the dentate line, that they receive their blood from the superior hemorrhoidal plexus, and that they're covered with columnar epithelium. Furthermore, they are not sensitive to pain, touch, or temperature unless they really prolapse out, and they cause hematochezia, bleeding, bloody stool. Now, typically, the degree of hematochezia experienced with an internal hemorrhoid is not really enough to cause you to seek treatment. It might go away on its own. It might stop bleeding. It might scar up. However, an internal hemorrhoid might prolapse, and that's what it looks like here in the middle, just like a beautiful flower. So external hemorrhoids, the SDL tells you on this page 16 all that you need to know about those as well. They originate below the dentate line. They're lined with squamous epithelium. They're supplied by the inferior hemorrhoidal plexus, and they do present with pretty severe pain. And the big complication of those is thrombosis. So as wise Dr. Goyan has communicated to me, now I to you, internal hemorrhoids bleed, external hemorrhoids thrombose. Principles of treatment: get the fiber up in their diet, adequate fluid intake. If they ask you, like, what's the best non-invasive, rubber band ligation, you just wrap a rubber band around it and choke it off and hope that it just falls off. So that's it for that 16-page SDL. I hope you enjoyed it as much as I did.